Hello and welcome to Wellness Wednesday. This is the first lesson in the Healthcare Navigation 101 series, and today's lecture is called Who's Who. So, for those of you who have never attended a Wellness Wednesday in the past, I have had one series all ready for Wellness Wednesday that I started late December, early January of this year. And I believe that one was a total of 10 lessons, and it kind of talked about the different pillars of wellness, what sorts of things contribute to genuine wellness. And that was things like exercise and hydration and nutrition. And I sort of drilled down into each of those really pretty commonly understood topics of wellness and gave a little bit more of the detail on why exactly those things contribute to your health and address some common misconceptions. And with Healthcare Navigation 101, I'm hoping to address a lot of the same sorts of misconceptions that are common among folks who are really just trying to access healthcare. Okay, so accessing healthcare is something that I feel absolutely should be regarded as a human right. I think that we all have a right to get good advice on how we can keep ourselves the healthiest and how we can remain pain-free. And so that's kind of why I decided to do the healthcare navigation series. And if you are interested in seeing an outline for this, you can visit patientphysicaltherapy.com/blog. And I'm going to do a quick screen share here to show you what that looks like. So this is my website, Patient PT. And if you were at the home page, all you would have to do to access the blog is go to About and then Blog on a desktop. It's a little different on a phone, but essentially that. And then this is the home page for this episode of Wellness Wednesday, Healthcare Navigation 101, Who's Who. And you can see that there's a Facebook Live event that links back to this page that you are likely watching on right now, and a group discussion link for after I actually finish doing this sort of more lesson lecture portion of the video. So if you'd like, feel free to download a copy of that outline and kind of follow along. I'll be referencing back to it throughout this lecture, mostly to kind of keep myself on track. So, Healthcare Navigation 101, this introductory sort of lecture last week was just preparing you all for some of the reasons that we're talking about this. This week we're talking about different healthcare environments and who the different players are in our modern healthcare system and how they are sort of fitting together realistically these days. Because there are a lot of folks who sort of grew up in one kind of healthcare environment, and over the last 20 to 30 years that has evolved enormously. There have been a lot of advances in medicine, and that's part of the reason for that. But that is mostly what we're going to be talking about today, and future topics will include things like health literacy. So next week I want to do some talking about how we really got here and why managing wellness has become really difficult for a lot of us these days and why it's so expensive, especially here in the United States. And another topic that will probably come into play quite a bit during that lecture is why it's so hard to get a definitive diagnosis for a lot of conditions these days. But today we are mostly going to be talking about the different players in the healthcare world and who they are and what kind of the differences are. So I wanted to start off by talking a little bit about sort of the big picture of healthcare in the United States. And I sort of boil that down to three major areas. Okay, the first one is primary care, which is sort of its own little very important piece of the healthcare system. And then there is what we call inpatient environments and outpatient environments. So an inpatient environment is anywhere that the patients actually stay in the facility. Okay, so that the most common example, of course, is a hospital, but skilled nursing facilities, also known as nursing homes, are another example. There are also hospitals that are specifically rehabilitation hospitals that folks like my friend Suzanne work at. and a number of other different inpatient facilities, including mental health inpatient facilities. And then the outpatient side is more the clinic-based providers that a lot of us see on a more regular basis. So outpatient is any environment where the patient comes and gets their medical care, medical services, and then leaves again and goes home and stays there overnight. So that can be things like my physical therapy clinic here, any other physical therapy clinic, private practice, healthcare providers of various types work in outpatient environments. And then there is another side of things, the sort of big picture of the different approaches to healthcare. Okay, so the primary example of different approaches to healthcare that folks think of here in the United States is the medical approach and the pharmaceutical approach. And there's also the rehabilitation approach, which is kind of more my area. And of course, there is mental health and social work that fit together with all of those pretty seamlessly in our healthcare system, or at least ideally they would. And the one that I'm going to focus the most attention on today is the primary care environment, because I think that that is sort of a source of a lot of confusion for folks. So first of all, what is primary care? A lot of folks really only are familiar with the concept of primary care because of health insurance. So a lot of health insurance companies will require that you have a primary care provider of record. So like Blue Cross Blue Shield is a big one that oftentimes they will encourage you when you first sign up for a new insurance program or get onto a new employer that has their insurance through them, that you establish a primary care provider. And a lot of folks think of primary care providers as sort of the way to access specialists or the person that you go to get your prescriptions filled. And some folks think of them as the folks that you go to for checkups. And all of those things are true. But at the end of the day, the primary care provider serves a very specific and very important purpose in the healthcare world. And essentially, they are the only person in the healthcare world that is responsible ultimately for understanding you as a patient. That may seem a little odd, okay? You would think that most people who are touching your healthcare would understand you as a patient, understand your case. But unfortunately, the way that a lot of healthcare works these days is, especially when you get to the professional level, which is like the doctorate level of healthcare, there is a lot of demand. There are a lot of patients that need to be seen, and there are huge expenses for both patients and for providers. And so to keep those things in balance, what a lot of healthcare institutions end up doing is essentially scheduling their professional level providers, especially, to the highest level of productivity possible. And really, at this point, that is extending throughout virtually every part of the healthcare system, all the way from doctors like neurosurgeons and those primary care providers down to nurses and certified nurses assistants and techs. Everybody who sort of has a particular skill set in medicine is essentially expected to perform at the highest level of that skill set at virtually all times. So in the primary care environment, I think that that model is particularly difficult for a lot of healthcare providers to deal with, because I want you to imagine, if you will, that you're in a job that you have a lot of job security. You can always find a job, but you are in so much demand that every minute of your day, every day, is scheduled. And when it comes to physicians, especially in an underserved area like Bloomington, that can mean that every minute of every day is scheduled for 3 months or 4 months or 5 months into the future, sometimes even 6 months into the future. And from a patient standpoint, that's incredibly frustrating, because if you don't have a primary care provider already, or sometimes even if you do, it's really difficult to get in for an appointment on a short notice. But another aspect of it that I think kind of gets lost in the shuffle is that it's really overwhelming for the providers themselves, because not only are they scheduled months and months in advance, they are scheduled so closely together that a lot of times there isn't much time in between patients to review files and sort of get to know what's in there. So that's why primary care providers are really important. The idea of a primary care provider in an ideal world is that that primary care provider will not only be the most familiar with your case and your history as a patient, all the different things that you've been through, tests that have been done on you already, things that have been determined, but they also will sort of keep track of you in the rest of the medical system. So some of you may be aware that we don't really have like a unified medical records system. There's been a lot of talk about electronic medical records and universal medical records and things like that over the last several years. But if you have been to more than one provider, you may have already run into the fact that it actually can be really difficult to make sure that your medical records go from one institution to another. So that is an advantage sometimes of getting most of your care through sort of a larger umbrella institution. And I don't really like to name names of other healthcare providers in this area, but let's say that there is a loosely university affiliated healthcare system that a lot of folks go to in this area. One advantage of using that healthcare system might be that all of your specialists and the people that you see for different conditions that you face are able to access your records for that whole system as opposed to just their office. And that's not universally the case, even with larger healthcare systems, but it's at least somewhat more likely that your provider will be able to access your records without sort of needing to fill out paperwork, because a lot of times that's the process. You have to actually go to the provider, go to their website, download a form, fill it out, fax it in. They have to fax it off to somebody else. A lot of times the records can only be transmitted via fax because of security issues, and it really can be quite difficult to exchange medical records among other providers. And so that's really sort of what it all comes down to with a primary care provider. It is their job to sort of keep track of you and to know that you are seeing a neurologist for one condition and a pain management specialist for another condition and a physical therapist for both of those conditions. And make sure that there isn't too much crossover, okay? And pharmacists also a lot of times have some responsibility for that, because oftentimes they are the only people who have any awareness of all the different pharmaceuticals that you have perhaps been prescribed by those different providers, okay? So that's really the purpose that primary care is supposed to serve. And there are a few different kinds of primary care providers. So and again, speaking mostly in the medical world, you may have seen that some doctors have the initials MD and some have the initials DO. And MD is pretty easy to guess. It stands for medical doctor. DO stands for doctor of osteopathy or osteopathy. I'm not really sure what the most popular way to pronounce that one is. Common point of confusion in the medical world as well. Not everybody pronounces everything the same thing. But anyway, a DO and an MD are actually both doctors, as people normally think of them. They're both types of physicians who can serve as a primary care provider, and they have all the rights and privileges associated with being a doctor. Okay, they can prescribe, assuming that they have the relevant training and expertise. They can do surgeries, they can do all the stuff, okay? And then there's sort of a distinction between the two in that the doctor of osteopathy, DOs, have more specialized training in the musculoskeletal system. And there are a few other subtle differences, but ultimately it comes down to the concept that DOs are sort of better trained and focused on being more of a primary care role, because DOs are sort of focused on treating a whole patient. If you look at some of the education system information and stuff like that, that is sort of what it comes down to over and over again, is that the DO degree treats the patient holistically, which just means as a whole patient, whereas the MD is trained almost from the beginning to sort of isolate specific systems. And so the MD degree is sort of intended from the get-go to help people specialize in specific systems like oncology or urology or ophthalmology or general surgery or any number of other specialties that are within the medical community. And both of them can specialize, and both of them can be primary care providers who work in direct contact with patients, okay? So MD, DO, both doctors, both primary care providers, and they are considered equivalent degrees. There are a lot of misconceptions that a DO is perhaps like a different kind of degree, not as much education, things like that, and that's just not true. There are slightly different approaches to medicine in those two degrees, but ultimately not a huge difference other than a little additional training in musculoskeletal stuff for the DOs. Then there are also folks who end up a lot of times working with physician's assistant as opposed to a physician for their primary care. And a physician's assistant is a lot like what it sounds like, okay? Basically, a physician's assistant has a little less training than a doctor. They usually have an undergraduate degree, and I believe that their degree is a 2-year degree after their initial undergraduate. And they can do things like give stitches and order labs, and in some states they can actually prescribe as well. I believe here in Indiana, physician's assistants have to have oversight from a physician in order to prescribe. But basically, especially here in Indiana, the physician's assistant has to work directly with a physician, usually in the same office or system as they do, and kind of have more oversight than a physician would. Then sometimes there's confusion between what a physician's assistant versus a nurse practitioner is. Physician assistant and nurse practitioner are considered semi-equivalent degrees. A nurse practitioner degree is actually a master's degree after an undergraduate, which means it's a 2-year degree. Nurse practitioners can prescribe, do stitches, serve as a primary care provider. So there's really not a ton of practical difference between a physician's assistant and a nurse practitioner, except I believe here in our state, nurse practitioners have more authority to prescribe. But what all of that comes down to at the end of the day is that the physician's assistants, nurse practitioners serving as primary care providers are sort of extending the reach of physicians to some extent, so that more people can get primary care access. And one of the reasons that I wanted to talk about all of this is because I feel very firmly that physical therapists are going to be a primary care provider of the future. So physical therapists don't really work as much in primary care right now, but there has been more and more research over the last several years, particularly within military settings, of what the outcomes are when physical therapists serve in a primary care role. In military environments, physical therapists actually are sort of gatekeepers for physicians. So if someone is injured or they have an ache, pain, whatever, they will most times be sent to a physical therapist before they can go and see a physician. So if a physical therapist rules out various musculoskeletal injuries or posture distortions or any of the number of things that we work on, and they still think that that person needs to see a physician, then the person is routed to a physician. And the reason that I bring this up, and the reason that I feel pretty strongly that physical therapists were really more the primary care providers of the future, is because more and more research has been showing that low back pain is consistently something that is managed better with a rehabilitative focus and a wellness perspective than with a surgical and pharmaceutical approach, okay? So low back pain is something that I think about a lot. I work with a lot of people who have persistent pain, And it is the number one reason that folks visit primary care providers in the United States, or actually, I think it's number two. It's behind the common cold, I believe. But I was just reading a paper earlier this week, and here it is here. Not that, that's a very exciting view, but it's called Predicting Who Develops Chronic Low Back Pain in Primary Care, a Prospective Study. Okay. And essentially what this paper ended up finding out was that about a third of people who have experienced disabling low back pain end up having that pain persist over time. And it was more common among folks who are in older age groups and those who have a history of low back pain, and among women. And then it goes on to say that when pain persists for a longer period of time after the initial injury, some of the things that are sort of associated as premorbid factors can have a really big influence on who is and is not having persistent pain. And premorbid factors, some of you may be more familiar with that because of this whole COVID pandemic. It's like a pre-existing health condition, but the premorbid factors that this paper found to be most associated with persistence of symptoms were a little surprising, I think probably for most of us. So one of them was psychological distress. Another was poor self-rated health, low levels of physical activity, smoking, dissatisfaction with employment, and then also the duration of the symptoms and whether there was pain radiating into the leg or widespread pain were factors. So the reason that I bring that up is because the strongest statistics in this paper, and in many papers that are studying persistent pain conditions, things like psychological distress and poor self-rated health and low levels of physical activity are the strongest correlations. And people have this misconception, because a lot of folks understand that correlation and causality are not the same thing. Like, it may just be a coincidence, essentially. Studies like this end up getting really misunderstood very frequently. But what it all comes down to is that managing lifestyle factors like your personal stress levels and minor aches and pains that are occurring on a day-to-day basis and may not seem like such a big deal are really a very crucial part of managing longer-term health. Okay, so things like chronic low back pain, initially it may just be kind of a nuisance, but it is exactly the kind of condition that can really get you into trouble over the longer term. And so I say all of that to say that if you are going for a primary care visit and your goal is to address an ache or a pain, something in the musculoskeletal system, and you haven't had a serious injury, it may be a better use of your time to visit a physical therapist first. Because in the medical world of MDs, DOs, physicians, physician's assistants, nurse practitioners, their primary focus within medical care is on surgical approaches and pharmaceutical approaches. And what that means at the end of the day is if you go to a doctor, a physician, for a low back pain condition, you are most likely to be offered a pharmaceutical or a surgical intervention because that's where their training is. And if that's not something that you actually are looking for as far as your treatment is concerned, and especially if you're one of those folks who just straight does not like to take pills, does not like to have surgeries, don't really think that that is the solution for you, or at least it's one that you want to avoid over the long term, going to see a physical therapist first definitely makes a lot of sense, because as a physical therapist, I can't give you a prescription. I can't order an x-ray, actually, even here in Indiana, though that is another thing that's allowed in military environments for physical therapists. So I just have to keep working with you until I figure out exactly where the weakness is in your system. And in my experience, it seems like you're sort of more likely to get to the root cause of that pain. And a lot of times it's just like a area that has been injured at some point in the past, a lot of times a very minor injury, and a small difference in strength from side to side has developed and kind of spiraled over time. And that's exactly the sort of thing that a physical therapist can help you figure out from day one, as opposed to the sort of more common medical approach of waiting to see if it goes away, taking painkillers for at least a short period of time and waiting to see if it goes away, taking painkillers and getting a steroid shot of some kind and waiting to see if it goes away, and all while minimizing activity. The human body was made to move, and research in physical therapy has shown time and time again that more than a day or two of bed rest after especially a low back injury ends up resulting in worse outcomes over time. Okay, you're more likely to have more pain because your body basically needs to know that when you injure something, you still need that, and it needs to prioritize getting it fixed. So I wanted to talk a little bit more about medical specialization as part of this as well, because I think that it's a really crucial piece of the puzzle that took me a really long time to understand. So before you go to physical therapy school, and it's very similar for medical school for physicians, you have to take a series of prerequisites, and they're usually like really hard ones. Okay, so some of the prerequisites that I had to take for my physical therapy training was 2 semesters of physics, 2 semesters of biology, 2 semesters of chemistry, and at least 1 semester of statistics. And of all of those, I hated statistics the most. I'm really not the best with numbers in general. And so that one was really tough for me, but physics was a close second. That one was definitely really hard too. And there's a common perception, even among folks who are pre-med or pre-PT, that those prerequisites exist to kind of weed out people. Okay, so like if you're not as dedicated, if you're not willing to wade through these hard sciences classes, maybe you're not cut out to be like in the medical world. And there's actually a lot of that kind of gatekeeping within academic and medical environments. And so, you know, there may be some truth to that at the end of the day. But what I discovered as my education progressed is that all of those hard sciences actually come into play at some point during your training. So, for example, when it comes to physics, it would have been virtually impossible to understand a lot of the things about what affects ankle mobility if it weren't for physics, because the thing about the human leg is it's a series of angles. Okay, so if this angle is a little bit off, the one up above it is going to be a little bit off as well, and then the one up above that may need to compensate for it. And when it comes to understanding that from a physics standpoint, you need to understand the force of the ground coming up on the bottom of the foot and how that affects the angle of the joint, and how that's going to affect momentum when the limb swings, and all sorts of things that just aren't terribly predictable when you're learning about individual concepts like force and velocity and all of those kinds of things. Another example is biology. So I took a biology class where we went into a crazy amount of detail about how insulin is used in various living forms. And then during physiology, I believe second year of physical therapy school, we came back around to talk about metabolism and insulin and how all of those things work in the human body. And I remember having one of my very intelligent classmates, who generally speaking got better grades than I did, ask me after we had taken our class on metabolism and diabetes and all of those things that involve blood sugar, they said, "What is insulin for?" And I was somewhat blown away by that question. I had not found that topic to be as difficult as a lot of the other ones in physical therapy school. And I think that a big part of the reason for that was because I had had not just that biology class, but another class that was called Physiology of Human Disease that sort of put all of those things together in a really big picture way for me before I had to learn the really nitty-gritty details of all of the different enzymes and things that interact with insulin within the human body. Statistics is another one that, I mentioned earlier. I really struggled with that one. But statistics is also really important in medical care because you need to be able to understand the results of research papers like this one that I was alluding to earlier. And I think that it can be really difficult for people outside the medical world to understand exactly how complex a lot of the things that people in the medical world have to learn are. And so I wanted to um, talk a little bit about complexity in more detail. So I've alluded to the musculoskeletal system that physical therapists more specialize in. We also learn quite a bit about the nervous system, what connects your brain to the rest of your body. But there are all kinds of other systems in your body, and those are ones that a lot of other types of medical professionals specialize in, like cardiology and lymphatics and the vascular and cardiovascular system. And for me, I felt like a lot of it was just kind of this puzzle that I did not have a larger picture for, because you learn about so many things, even in physical therapy school, as like conditions of the shoulder or conditions of the elbow or conditions of the wrist or the hip. And what it really comes down to at the end of the day is that these are conditions of a human being. And I felt like things changed a lot for me after I had been through, of course, my entire educational process. I had graduated. And then the last thing to do was take my board exams. And I thought that most of my knowledge had sort of come together in a pretty big picture as part of my final clinical rotations, and they were incredibly valuable for that. But the process of studying for my board exams actually increased my understanding of how to treat a patient, not a shoulder, not a hand or a wrist, how to treat a patient so much more exponentially than I ever thought, because I had to finally take all of those little bits of information that I had learned and put them all together in one, I don't know, sort of usable body of information for a test. And I have a little visual aid here. Okay, this is the PT board exam study guide. Okay, and I just wanted to show you all how thick this is and how many topics there are. Okay, so every different color you see there is a different topic, a different major system of the human body that physical therapists have to study as part of their board exams so that they can finally get those initials, PT. And doctors have to learn all of that stuff and more, okay? And when you're finished with all of it, there's honestly no choice but to specialize probably more than you would want to. You cannot hold every single detail of things. You have to come to more general understandings about some things. And so when you go to a physician for a problem that would really be better addressed by a physical therapist with exercise and wellness training and things like that, you are, whether you need it or not, more likely to get a prescription or a sort of loose recommendation to wait until it gets bad enough that it needs to be operated on. That's something that a lot of folks will hear, like, oh, your knee hurts. Well, it's arthritis. Wait until it's bad enough, and then we'll do a joint replacement. And ultimately, that is how things go for a lot of folks, but it doesn't necessarily have to go that way. And it's nobody's job in the healthcare system to tell you, if you don't like that answer, that you do have the option of going and seeing a totally different kind of specialist. Even if your doctor doesn't offer you physical therapy, you can still go and see a physical therapist thanks to our updated Practice Act here in Indiana. You can access physical therapy without a prescription. You may have to pay for it out of pocket. There are a lot of insurance regulations on that as well. But you can go and see a physical therapist about that back pain, knee pain, especially if you ask for a prescription from your doctor. And most doctors will give you that prescription for physical therapy because at the end of the day, they do know that that's probably more in the long lines of what you really need. So that kind of brings me to the topic of different approaches. Okay, so I've talked about that a little bit, the pharmaceutical, medical, rehabilitative, and I think it kind of comes down ultimately to preventative prevention of disease, maintenance of one's condition, rehabilitation when needed, and then medical solutions. Like, to me, that's kind of the ideal progression through the medical system. In an ideal world, everybody sort of starts off doing all of the things that they need to do to keep their body healthy. And then they just have to maintain it as they get older and rehabilitate from injuries as they crop up, and then eventually access the medical system in order to take care of that musculoskeletal system. But unfortunately, not everybody starts in the same place when it comes to prevention and maintenance. Not everybody learns as much about how their body is ideally supposed to work when they're growing up. Not everybody's school district has the same sorts of health programming available. Not everybody has the same sorts of sports available in their school district. And so we all have very different ideas of what our responsibilities to our human bodies are. And that is, I think, sort of where the alternative healthcare providers come into. So there are a lot of folks who are dealing with persistent pain issues and sort of accidentally locating these gaps in the healthcare system where, you know, they've got a knee that hurts for years before they can have the, you know, cure, which is supposedly a knee replacement. And for the record, a knee replacement is not actually a guaranteed cure for knee pain. And that's a topic for a whole different day. But in between, what do you do? Okay, so a lot of folks end up going to alternative healthcare providers like acupuncturists, massage therapists, chiropractors to manage those day-to-day pains. Some people end up going to rheumatologists or other sorts of pain management doctors to get prescriptions for steroids or opioids or any number of different things that sort of help to control pain on a day-to-day basis. And there's nothing wrong with any of those things, but and I'm a massage therapist myself, and I will tell anybody any day that massage is absolutely an important and crucial part of a person's wellness, if they can afford it, if they can prioritize it. But all of us are sort of coming from different places. And I think that when it comes to alternative healthcare providers, a big part of the reason that they don't necessarily have, like, I don't want to say that they have a bad reputation, but you may have noticed that your physician may discourage you from taking advantage of things like massage therapy or acupuncture. And that's because ultimately those sorts of pain relieving, like directly pain relieving ancillary therapies, are more of a temporary solution. And I think a lot of people know that at the end of the day, but I think that what a lot of people really don't necessarily know is that there is a better way. Physical therapists now are all trained at the level of doctor of physical therapy, and so we all are getting this extremely well-rounded education featured in that PT exam book. And there is a lot that you can do in between my knee hurts and my knee needs to be replaced that a physical therapist can help you with. And unfortunately, because so much stuff is covered by health insurance these days, a lot of people don't end up getting that message because, you know, if your knee pain isn't bad enough that it is preventing you from doing certain things or whatever, if you can't get your healthcare provider to take it seriously for whatever reason, you may have difficulty getting that prescription for physical therapy. Your physical therapist may have difficulty getting that physical therapy covered by insurance. And so I say all that to say, I think that that's a pretty darn good argument for sort of going outside that system to access physical therapy or wellness training from a doctor or physical therapist like myself, who is in private practice and doesn't mess so much with insurance coverage, or at a minimum, a practitioner that is willing to work with you outside of your insurance system, because you may be surprised at how much value you can get out of a physical therapy visit when you don't have a health insurance administrator getting between you and the professional who has been reading your medical records and actually understanding what's going on, which is not always the case, which is actually very rarely the case when it's a health insurance company that's reviewing your records. So that sort of concludes the lecture-y, lesson-y training part of this week's Wellness Wednesday.